Hi, I'm Rachel.
And I'm Summer.
We are presenting on Prader-Willi syndrome.
So, Prader-Willi syndrome originates from a deletion or mutation of chromosome 15. The hallmark symptom is insatiable hunger. So imagine if you went to your favorite restaurant and you ate this big meal and afterwards you didn't feel satisfied, you still felt starving. So Prader-Willi syndrome is named after Andrea Prader and Hendrik Willi, and they coined the term Prader-Willi syndrome in 1956.
Okay, so the etiology, so there's 3 different types that they have discovered. It was actually discovered in 1956, but they didn't know anything about it and what caused it. It wasn't until 1981 that Dr. David Ledbetter had a breakthrough discovery, and so then he found out that most people actually have a missing segment of the gene on chromosome 15. So there are 3 different types here. So there's paternal deletion, which accounts for about 70% of cases, maternal uniparental disomy, I can't really say that well, but which is about 30% of cases, and then an imprinting defect, which is very rare. So here we actually we circled the little chromosome 15 right here, and I'll explain it in a second. Okay, so the breakdown. So the Prader-Willi syndrome by deletion is not inherited. It is just a random event that happens when the formation of the reproductive cells, either the egg or the sperm, happens. Or it also could be from the early stages of embryonic formation. So like I said, just kind of like a completely random defect that happens during construction. Paternal chromosome 15, so it is possible for genetic changes that abnormally inactivate the gene on paternal chromosome 15 to be inherited from the parent. So that's about 30% of cases. And then an imprinting defect, that is where genes are not active or expressed on the mother's chromosome 15 because her imprint turns off. So on the paternal side, often that's when the father's gene of chromosome 15 is deleted. And an interesting fact is when that happens on the mother's side, it also, that actually results in Angelman syndrome. So I just thought that was a really interesting fact to know.
Okay, so symptoms. So like we had talked about earlier, the hallmark symptom of Prader-Willi is insatiable hunger, and that's because the part of chromosome 15 that's affected affects the hypothalamus, which regulates your appetite. So in early development, some of your symptoms are going to be hypotonia, poor suckling reflex, which can lead to failure to thrive, low responsivity, underdeveloped genitalia, and they have distinct facial features. So some of those is going to be almond-shaped eyes, narrowing of the head at the temples, and then a thin upper lip. And then once it gets to childhood and adulthood, around age 2 is when that insatiable hunger starts, where they feel the need to eat. And that's when their intake of food is going to need to be very heavily regulated. So some of those symptoms is constant food craving, unusual food seeking, so maybe eating things that aren't food, rapid weight gain, hypogonadism. So that would be delayed or not having puberty at all, which also leads to infertility in adulthood. Short height, low muscle mass, high body fat, again because of that hypotonia. Delayed motor development, small hands and feet. Hypopigmentation, which we're going to talk about a little bit later. And then inability to regulate body temperature, again because the hypothalamus is affected. So some severities and variations. This is what Rachel talked about earlier. So Prader-Willi syndrome by deletion is the most common, and you can't detect that in amniocentesis. Maternal uniparental disomy is around 30% of cases, and then Prader-Willi by imprinting defect is around 1%, and it's super rare. So when we talked about that hypopigmentation, that's due to a mutation or loss of OCA2 gene, which is common in people with Prader-Willi's, and it leads to fair skin, fair eyes, and fair hair.
Okay, so assessment. So all of those things that Summer just talked about, definitely should be monitored by the pediatrician. That's why early intervention is so important. So when they start seeing all those things in young children, that is when genetic testing should be considered. So some of those things, just infant with hypotonia, poor suckling ability, and if you just have several characteristics of it and you've never been tested, or if an undiagnosed child or adult was tested with outdated PWS testing. So once they have been recommended for genetic testing, the test is called DNA methylation testing. And so that detects abnormal parent-specific imprinting on chromosome 15, which is what we just talked about. And that is the only test to really tell as far as like a blood test.
Okay, so incidence. In the studies that I found, there was a lot of variation, but it was anywhere between like 1 in 15,000 to 1 in 25,000. So it's pretty rare. There's an equal male to female ratio, and it occurs in all race and ethnicities. There wasn't a ton of information out there, but it did say that the hypopigmentation was common, so I would think that it would be more common in Caucasians, but I don't know, I couldn't find much on that. Oh, that's my slide, sorry. Okay, so prognosis, failure to thrive in infancy. So like we talked about earlier, the poor suckling reflex, a lot of the times they're not getting enough food intake as an infant. And then potential lifespan shortening due to comorbidity. So that would be obesity is the major one, because if their appetite isn't controlled and their food isn't monitored, then obesity obviously comes with, diabetes, heart problems, and all of that bad stuff. And then also delayed puberty and infertility. So a lot of the times that can make someone with Prader-Willi feel like ostracized by their peers when like everyone's going through puberty and they're not. And then later in life, if they want children, having to deal with infertility obviously has some mental health impacts. And then the chart that is in the corner, so that's showing the percentage of people with Prader-Willi in a study that was done that were obese. So 41% were severely obese, 55% were obese, and then only 4% were normal. So obviously that has like a huge impact on this group of people. And then there's also a video included. We're not going to play it now because that would be kind of weird. But it's the girl from Big Bang Theory, and I guess she's an advocate for Prader-Willi syndrome. But she talks about like how much it has an effect on their lifespan and like how important it is to do more research on it because there really isn't a ton.
Cool. So the comorbidities, as Summer was just saying, most often you see children that actually are obese, which causes a bunch of issues, type 2 diabetes and all of that. That's on the next slide. But also developmental delay. 90 to 100% of children with this syndrome achieve early milestones in double the time that it takes other children to take. So that's a significant thing to note. Also cognitive impairment, impaired language development, so often they will need speech therapy. Hypogonadism in both sexes, and that's when the genitals are not developed properly or appropriately for their age. Sleep abnormalities, that could be due to just being obese or not getting the nutrition or the food that you need, which would cause behavioral issues. That makes sense. Also, sensory processing disorder is on there as a comorbidity. Complications. So all those things that I just said, this really just makes sense. So these are all obesity-related diseases, type 2 diabetes, heart disease, high blood pressure, sleep apnea, joint pain, and mental health issues. So childhood obesity is a huge thing. That could cause a lot of complications later down the road. And so that's what's so sad about this syndrome is it really needs to be monitored and really you need a dietitian and all of that to really try to get this under control as best you can while they're still young to prevent a lot of these things from happening.
So deficits in function and performance, a lot of these are going to go hand in hand with what Rachel just talked about. So behavioral problems, and really this makes a ton of sense when you think about it because like when you're hungry, like I don't know about you, but I get like
hangry.
Yeah, I get hangry, like I'm grumpy, I'm not a fun person to be around. So they have a lot of problems with behavioral management, feeding difficulties as an infant, and then again like controlling food intake as an adult or as a child. Poor growth as an infant because you're not getting enough food intake. Hypotonia, that affects through the lifespan. Delayed development, like Rachel said, 90 to 100% of people with Prader-Willi syndrome, it takes them twice as long to reach those important developmental milestones. Weight regulation, becoming obese later in life, which leads to other health problems and mental health problems. And anxiety is really common with people that have Prader-Willis. And the chart that is right here shows the symptoms that people have with the different kinds of Prader-Willi syndrome. So 100% of the people in this study had hypotonia and feeding problems. Developmental delay was with 100% of them. Facial deformities, hypogonadism, and sleep disturbances. So also, like, if you're hungry and you're not getting a good amount of sleep, again, like, those behavioral problems are going to be severe.
So for the medical management, so there's no medication, unfortunately, for the hypoplasia, which is just insatiable hunger. Gastric bypass is not recommended, obviously, for children. There's a lot of nutrients that they are not getting. In infants, tube feeding is recommended, OT, PT to improve strength, hormonal or surgical treatment for cyprotorchidism. That's a hard word, sorry, no. In childhood, then strict supervision of food intake. As we were saying, often they have to lock their cabinets so the children don't get more food than they need. It recommends that the parents work with the dietitian so they know that their child is getting the correct nutrients for how much energy intake and outtake, so just that balances out, so to prevent obesity. Encourage physical activity, and they also sometimes will do HGH replacement to normalize height and weight, and then also sex hormone replacement because they are having a hard time with puberty and all of that. And then treatment of conditions, so kind of as I said before, OT, PT, speech therapy, dietitians, nutritionists, and sensory integration.
Okay, so we're running a little over, so I'm going to briefly go over this. But for the deficits, that's going to be what we went over before. And then, so as an OT, caregiver education is really important because you're having to teach the parents, telling them that they need to go to a dietitian and having to work all this out and getting the locks for the cabinets and all that kind of stuff. The medical management that Rachel just talked about is going to be crucial. Early intervention because of the problems that they have in infancy and failure to thrive. Therapeutic exercise, which can help with obesity later in life. Activity modification and sensory integration.
And here are our references.